Welcome to our introduction of the endocannabinoid system. The knowledge we're sharing today is the foundation for understanding why cannabis is such a safe, versatile, and effective medicine. Hello, I'm Nisha Whiteley, your moderator for this module and the Chief Operating Officer of CReDO Science. After my mother passed away from lung cancer, I was inspired to find a way to help others benefit from her remarkable end-of-life experience with cannabis. It helped her in ways that the pharmaceuticals did not. It provided relief from anxiety common to terminal patients, relief of nausea and pain, and it stimulated her appetite. Maybe most importantly, cannabis made it possible for her to be present the last few weeks of her life and to enjoy the parade of people that came to pay their respects. That was an enormous gift to all of us. Her experience with cannabis led me down a 5-year research journey that culminated in the publishing of the book Chronic Relief, A Guide to Cannabis for the Terminally and Chronically Ill. It was through this project that I had the good fortune to meet Dr. Ethan Russo. Over the last 10 years, we've had the opportunity to become friends and colleagues. Dr. Russo is a board-certified neurologist, psychopharmacology researcher, and author. He is the founder and CEO of our company, CReDO Science. Dr. Russo is the preeminent medical cannabis expert. He is the person experts worldwide turn to for advice. His work includes over 20 years in neurology practice and a lifelong study of medicinal plants and over 16 years working with GW Pharmaceuticals, the only company to receive FDA approval for whole plant cannabis drug. He has participated in over 23 clinical trials with cannabinoid drugs, been the author or co-author of over 70 papers and 7 books, and lectured on this topic in 39 countries. I'm pleased to welcome Dr. Ethan Russo.
Thank you so much, Nisha. Well, let us get into our first subject. So, welcome. Well, as you've heard, this is a bio on Nisha Whiteley that we'll welcome you to read when you consult the slides separately. These will all be indexed to appropriate other sources when needed. Same for me. And let's begin our subject. Of course, today we're looking at the endocannabinoid system. So this was a fascinating scientific development. Cannabis came to the attention of Western scientists about 150 years ago. And during that time, there was a search for the so-called active ingredient in cannabis, which was largely unsuccessful until Raphael Mechoulam and colleagues identified it in 1964. But how it worked remained a mystery. It took another generation before receptors were found in the brain where THC lodges, and subsequently with the additional discovery of endogenous ligands, natural chemicals within that work on the same receptors, it was the beginning of the understanding of the endocannabinoid system, which we will discuss in more detail now. So what is the endocannabinoid system? As you see here, this is the major homeostatic regulator of human physiology. To break that down a little bit, homeostasis is a natural balance. So if there's too much activity in a system, the endocannabinoid system will work to bring it back into line. Similarly, if a system is underactive, it will bring it back up to where it should be. As you see in the diagram, this is widespread through the body. We often talk mostly about the brain, particularly as a neurologist. This is of greatest interest to me. But as you see, it's also in the spinal cord, peripherally, and in the enteric nervous system in the gut. In in this and other courses, we'll go into a great deal more detail about how this works. This is just a link to an article done with Andrea Homan about cannabinoids and pain management. And as you see here, there will be links to get you to these resources. Additionally, all my articles and book chapters will be available at ethanrusso.org at the library tab. So here we have a diagram showing a little bit about the system. I like to say that it all began with a plant called cannabis. So as you see up on the upper left, there's the plant. In the unfertilized female flowering tops, there are these glandular trichomes, the sort of crystal balls that you see at the end of the stalks. These produce THC, which is analogous in its function to anandamide, the first discovered cannabinoid first endocannabinoid. So both of these bind to a receptor, which is called CB1, cannabinoid 1, and anandamide and 2-arachidonoglycerol, 2-AG, also bind there. The endocannabinoid system is present throughout the animal kingdom, at least down to the primitive chordates. And you see that the CB1 receptor is well preserved in higher animals. And it's only when you get down into invertebrates like the leech that there's significant differences. This slide is from the early writings of John McPartland, and we'll have links to that. This shows it in graphic form. And through scientific study, it is possible to look at the phylogeny of these receptors. And it turns out that this is an ancient system. Cannabinoid receptors are at least 600 million years old. Interestingly, the cannabis plant is only about 30 million years old, and the human species less than 1 million years old, just to place it in context. So although we would like to anthropomorphize about this, cannabis wasn't put on God's green earth to get people high. It is one of the happy accidents of nature that has formed much of medicine throughout human history, that coming from plants. Interestingly, insects have no endocannabinoid system. There are insects like this that will prey on cannabis, but the lack of an endocannabinoid system may indicate why insects have no sense of humor. There are important species differences. This is an early study of the endocannabinoid system going back to 1990. They use tritiated CP55940, which is a high potency cannabinoid agonist to map receptor density in the brain of different species. Interestingly, as one example, the density of CB1 in the cerebellum of dogs is much greater than that of humans. Historically, we can tell you that before THC was discovered and cannabis was a mainstream medicine in the United States, dogs were used as a primitive assay for cannabinoid activity of the preparations that were made, because when the dose was too high, they would develop a static ataxia, meaning wobbliness on the feet. A study from Michelle Glass showed the development in humans. The endocannabinoid system is critical to early brain development and architecture. It has a lot to do with what appears when. And interestingly, CB1 density is much greater in fetal and pediatric brains. Cannabinoids actually come in 3 different varieties. The phytocannabinoids are plant-based, and in general, these are what are called terpenophenolic 21 carbon compounds that come in the genus cannabis. there are a couple of exceptions in nature, and one example we'll hear about more later when we discuss plants in the endocannabinoid system um, would be Helichrysum umbracularigerum, which produces cannabigerol and actually a lot of related cannabinoid structures. As we've heard, there are also endogenous cannabinoids, natural endogenous compounds who bind to the cannabinoid receptors. The first one was anandamide, and its functions have been characterized by Professor DiMarzo as relax, eat, sleep, forget, and protect. However, we could apply 30 other descriptions to it and it would equally apply. Also, there's synthetic cannabinoids, one example, agellinic acid, that also affect cannabinoid receptors. This is a diagram of the structure of the CB1 and CB2 receptors in humans. And you'll see that they look alike, although CB2 isn't as long. In terms of their distribution, CB1 is very heavily present in the central nervous system, the peripheral nervous system, also in the sex organs. Among other things, it modulates pain, movement, emotion, whether one will vomit or not, have a seizure or not. CB2 is thought of more peripherally, but will appear in the brain under conditions of disease or inflammation. So it has a particular predilection to the immune system, the spleen, the tonsils, lymphoid tissues, and again, the peripheral nervous system. So it modulates immune function, inflammation, and pain. Importantly, it's not a psychoactive receptor. So if there is a molecule that stimulates CB2 but not CB1, it will not produce any kind of intoxication. An important point is the structure of CB2 is extremely different in different species. So I would be very suspicious of CB2 research done in non-human species or where humanized receptors have not been employed. Let's talk a little bit about receptor activity. Now, this is pretty basic, but an agonist is a compound that stimulates the receptor, and these can be characterized as partial or full agonists. So importantly, THC is a partial agonist at CB1 and CB2. Interestingly, anandamide is quite analogous, also a partial agonist at CB1. There are also antagonists at cannabinoid receptors, and these can come in two different flavors. A neutral antagonist will occupy the receptor, but doesn't really alter the activity otherwise. An example there would be tetrahydrocannabivarin that we'll hear a lot more about later in the courses. And there can be an inverse agonist. An example there would be rimonabant, SR141716A, which was briefly on the market in Europe as a diet drug, but had to be taken off due to side effects. And the reason for that is inverse agonists actually decrease the overall activity of the endocannabinoid system. That is, lower endocannabinoid tone. Additionally, there can be allosteric modulators. So these would not bind to the regular orthosteric site of the CB1 receptor, but other areas called allosteric sites. And again, these come in two flavors. A negative allosteric modulator, an example there would be cannabidiol is a NAM at CB1. And there can also be positive allosteric modulators. Synthetic ZCZ11 is one, and there may be natural examples. This is what happens at the level of the synapse. So again, the endocannabinoid system is the internal homeostatic regulator, and there are three components. The endocannabinoids the cannabinoid receptors, which not only include CB1 and CB2, but the TRPV1 and possibly other receptors. Also, they're regulatory enzymes. Now, it is often mistakenly said that the endocannabinoids are neurotransmitters. They really are not. A neurotransmitter would go from the presynaptic neuron to the postsynaptic neuron. And in this instance, the endocannabinoids rather are neuromodulators, and they're produced in the postsynaptic neuron on demand and go in a retrograde fashion to affect CB1, where they actually reduce the release of neurotransmitters. So if we look at this neuron, it's a glutamate receptor. So if we're inhibiting a stimulatory glutamate, the net result is inhibition. If, on the other hand, this were a GABA receptor and you're inhibiting the inhibition, there's a net stimulatory effect. Additionally, beyond 2-AG and anandamide, there are a whole host of other endogenous cannabinoids, related structures that may be relatively active or inactive, but they seemingly work together in what Professor Meshulam and Ben Shabbat called the entourage effect. And we'll hear more about this subsequently. In terms of distribution in the brain, CB1 is highly expressed in areas that affect pain, nociceptive areas. Also in the cerebellum, the limbic system, which deals with emotions, the basal ganglia related to movement, and also in reward pathways. There are areas in the brainstem where you find particular CB1 expression, like the substantia nigra and the periaqueductal gray matter, but not a lot in the brainstem or the medullatory respiratory centers. So there is no known dose of THC or related drugs that can produce respiratory depression, which is the problem with opioids. Back to the other areas, it's important to note that CB1 is the most abundant G protein coupled receptor in the brain. And actually, there are more CB1 receptors than there are for all the neurotransmitters put together. And again, a list of different functions, modulating pain, memory, movement, emotion, appetite, emesis, seizure threshold, GI motility, and secretion, among others. More on CB2. Again, mainly a peripheral immunomodulatory receptor with an important role in pain, inflammation, and physiological defense. Also, very important as an agent to treat fibrosis in the liver and possibly other organs. A wonderful article from Professors Pacher and Meshulam looked at the function of CB2 in all the various organs that you see here. This is a good one to come back to later in your self-study. And additionally, CB1 and CB2 appear in the skin. Now, this shouldn't be such a big surprise. The skin is ectoderm, as is the brain. And so there are a lot of analogies. Just as a tidbit for later discussion, cannabidiol, in addition to being anti-inflammatory and reducing bacterial load, it's also an agonist of the TRPV4 receptor. And so it's a sebastatic agent that could help acne. Sebum is the material that is the feedstock for the bacteria involved in acne production. A little detail about TRPV1, which is an ionotropic cannabinoid receptor. So it's best known as where capsaicin, the active ingredient in chili peppers, works. It's easily desensitized by ligands, and so something that stimulates it eventually will reduce its activity. Interestingly, anandamide also works there. Other things that stimulate this are heat, acid, and ethanol. The distribution is similar to that of CB1. Dorsal root ganglion, spinal cord, other areas of the brain, and hippocampus. So this is involved in neuropathic and inflammatory pain, itch. It regulates vascular tone. It can be involved in excitotoxicity and a variety of other conditions. So if we have an agent that desensitizes this uh, by an agonist such as capsaicin, or in fact cannabidiol is also an agonist there. This will put the receptor in a refractory state such that you don't get transmission anymore. What actually occurs in this desensitization is a loss of receptor activity when the agonist is there. This is due to a conformational change in the TRPV1 receptor or even a loss of those neurons. This can affect expression of things called substance P and calcitonin gene-related peptide. There's a phenomenon when these compounds are present called tachyphylaxis, a diminishing response after repeated administration. And this is where the receptor goes from an open, active or susceptible conformation to one that's closed and resistant. And TRPV1 agonists come again in two flavors, capsaicin, which is pungent, and CBD, which is not. So if you had CBG on your tongue or skin, it would not burn the way capsaicin does. So to have a therapeutic agent affecting TRPV1, ideally, it would not strongly activate TRPV1 acutely to cause pain, but lead to this desensitization. This is a study that from Basogno a little over 20 years ago, this is the first study that showed cannabidiol had effects on the TRPV1 receptor. And in fact, it is about as potent as capsaicin is in this kind of assay. At 10 micromolar, CBD desensitized the TRPV1 receptor to capsaicin activation. And as I wrote in a subsequent article, this is the same as turning down the heat and pain. So how might this be applied clinically? Well, certainly capsaicin has been used as an ointment for diabetic neuropathy, and similarly other types of neuropathic pain like causalgia or complex regional pain syndrome and skin burns might be treated with such an agent. TRPV1 active drugs have been used for irritable bladder, interstitial cystitis, and prostatitis. Also, chronic pelvic pain could apply to fibromyalgia, inflammatory bowel disease, and irritable bowel. Pancreatic pain, where there's a heavy representation of TRPV1, one of the most terrible kinds of pain. In atopic dermatitis and pruritus. Interestingly, anxiety areas in the brain are heavily innervated by the TRPV1 system, and this may have application there. It's a matter of getting it to the right place. Capsaicin is not absorbed well through the gut, but CBD can be, and we know that it has a predilection for the brain. Also, it's possible that this could be a treatment for cannabinoid hyperemesis syndrome, something about which we'll hear much more later. Although the problem is most cannabidiol preparations also have THC in them, which needs to be avoided with people who are susceptible to that condition. A little more about distribution of the endocannabinoid system and how it works in these different organs. Beyond what's diagrammed here, the ECS is also active in cardiac and bone physiology. And again, another interesting tidbit, cannabidiol actually stimulates bone fracture healing. And it may be the case in the future when athletes go to the emergency department with a broken limb that they'll get a cannabis-based medicine. A concept about which we'll be discussing more in future modules is the entourage effect, previously mentioned. This was first written about in 1998 in relation to those active and inactive endocannabinoid molecules. But the next year, Professors Meshulam and Ben Shabbat extended this to the cannabis plant. To quote, this type of synergism may play a role in the widely held but not experimentally based view that in some cases plants are better drugs than the natural products isolated from them. So at that time, 25 years ago now, they thought this was more theoretical than proven. However, in the intervening generation, we have shown many examples of how this is true. And this has certainly been a focus of my research personally. And we will discuss the interplay of phytocannabinoids, terpenoids, and flavonoids subsequently in the various courses. So one way of thinking about this synergy is getting more than the component parts. So 2 plus 2 doesn't equal 4, but is equivalent to 5. In terms of how you make and break down these molecules, as mentioned before, anandamide is a partial agonist at CB1 and CB2. Its precursor is N-arachidonyl phosphatidylethanolamin, or NAPE. It's broken down by several hydroxylases, especially fatty acid amide hydrolase, or Fa. 2-arachidonyl glycerol is actually a full agonist at CB1, but the two have different functions in different areas of the brain, and it's a very complex set of studies. It's synthesized from something called PIP2 via diacylglycerol lipase, and it's broken down by lipases, hydrolases, and esterase, the most prominent being monoacylglycerol lipase, or MAGL. Now, we have touched a little bit on what happens when you don't have enough endocannabinoid function, but it's also possible to have too much. The most common scenario for this is in type 2 diabetes mellitus and in the metabolic syndrome, where people tend to be overweight, have inflammation and additional problems. Interestingly, in cannabis, both CBD, a negative allosteric modulator at CB1, and THCV, a neutral antagonist at the receptor, look to have clinical value in treating these conditions. Let's talk about deficiency. First, in 2001, I published a section in a book about what I term clinical endocannabinoid deficiency. So the hypothesis at that time was that all humans have an underlying endocannabinoid tone. That is based on what the levels of anandamide and 2-HG are, their production, their breakdown, and the relative abundance and state of the cannabinoid receptors. The theory was that there could be certain conditions, whether you're born this way or develop it later, where endocannabinoid tone becomes deficient and produces disorders, pathophysiological syndromes. I developed this theory because in neurology, many deficiencies of neurotransmitters lead to diseases. So in Parkinson's disease, we know that there's a dearth of dopamine. In memory problems in Alzheimer's disease, there's insufficient acetylcholine activity. And to some extent, we relate depression to too little serotonin, although it's much more complicated than that. I thought that there should be conditions in which there was deficient endocannabinoid function. This was first published in detail in this study from 2004, and I focused on 3 conditions, and we'll hear more about these later: migraine, fibromyalgia, and irritable bowel syndrome, but also hypothesized to have involvement in these other conditions. turning to effects in cancer, this is a picture of a brain tumor in a child. Primary effects of cannabis in cancer are promotion of apoptosis. Um, Apoptosis is programmed cell death. That function is turned off in cancer and leads to wild growth. Also, inhibition of angiogenesis. Tumors make their own blood supply. Inhibition of metastases by limiting tendency of migration in cancer cells. Secondary effects are benefits on nausea, mood, and better function of the bone marrow to produce blood cells. Also reducing pain and reducing the need for opioids. Plants and pain have a long history in humans. And here are four of the main examples. From the upper left, the opium poppy, Peppervir somniferum, willow bark, salix species, chili peppers, as we've heard, capsicum species, and finally, cannabis sativa and certain other plants that affect the endocannabinoid system. Just a little more detail, a little bit tangential. Opium poppies were used for thousands of years for pain, diarrhea, and sleep. It wasn't until 1804 that the most active opioid in the plant, morphine, was isolated. This is the basis for subsequent opioids, including synthetics. But between 1804, it wasn't until something like between 40 and 50 years ago that natural endogenous compounds, endorphins and enkephalins, were discovered. Willow bark, again, is similarly ancient, used as a traditional anti-inflammatory. And this is the basis for the first semi-synthetic for pain, acetylsalicylic acid, better known as aspirin, in the late 19th century. Again, decades went by before the discovery of prostaglandins that explained why this worked. As we've heard before, chilies have been used for millennia for spice. This is a New World plant. Previously in the Old World, black pepper also has activity on TRPV1. Capsaicin was identified in 1816, and again, the natural ligand for TRPV1 and the prototype for the entire endovanilloid system. Then we come back to our subject, cannabis sativa. Food, fuel, fiber, and pharmacy. Again, best from the unfertilized female flowering tops. This is a dioecious annual plant, meaning that it has sexes on different plants and it is in the Cannabaceae family along with hops. Now we're going to take another tangent and talk about the microbiome, bacteria in the gut. This has proved to be an important regulator of how our energy works, how our fat is deposited, etc. So our guts harbor 100 million microorganisms. They're very densely there, and their combined genome exceeds that of human hosts 100-fold. There are different classes of these. Obese humans have lower bacteroidetes and higher Firmicutes counts. The microbiota, or these bacteria, regulate serotonin 1A, BDNF, and NMDA expression. These are all neurotransmitters. So they have an effect on the brain. It's a remote kind of effect. Interestingly, in Parkinson's disease patients, there was a pro-inflammatory dysbiosis or imbalance in these bacteria. When human gut microbiota from Parkinson's patients were administered to mice, they developed motor problems. Now, how did this system evolve in humans? Well, they compared the human populations to that from other primates, wild chimps, bonobos, gorillas, etc. And chimps are only about 2 percentage point different genetically from humans. To quote, the microbiomes of USA humans are more different from those of Malawi humans than from the gut microbiomes of Malawi humans are from bonobos. And that was extremely statistically significant. It was noted that humans on 3 continents had lower diversity of the microbes than apes and bacterial phyla, classes, orders, families, and genera. Americans average 30 fewer bacterial genera, the lowest level of diversity. Now, why is this important? Well, certainly this may account epidemiologically for problems that we're seeing in modern times that just weren't as prevalent in the past, particularly gastrointestinal disorders, uh, obesity, and autoimmune diseases really stand out in this regard. There are 10 to the 13th power bacterial cells in the human colon. In apes, their colon is only half of the intestinal volume versus 20% in humans. There have been changes in the bacterial lineages over 15 million years. And again, in industrial nations, there is a dearth compared to that on people pursuing more, what would you call it, Paleolithic lifestyles. Additionally, there are 2 kinds of bacteroideaceae lineages in apes that have never been found in Americans. Another tidbit, the severity of our irritable bowel syndrome symptoms is inversely related to the gut bacterial diversity. So the fewer there are, the worse the symptoms. There's an important relationship, as previously alluded to, between the gut and the brain. This is what's called the gut-brain axis. So there are associations of depressions with elevations of inflammation and pro-inflammatory cytokines. When people ingest what are called probiotics, bacteria, including the bifidobacteria and lactobacilli, this reduces negative mood in humans in several studies. In obese humans, the microbial composition was related to performance on cognitive tests, the trail-making test. That affects motor speed, attention, and cognitive flexibility. Again, when probiotics were administered to elderly people, they had improved attention and working memory. Also, fecal transplantation in 18 autistic children improved behavioral and gastrointestinal signs and symptoms. It's often an overlooked problem that these children have a lot of gut problems and symptoms related to that. Additionally, there have been relationships noted between the gut microbiome and other neuropsychiatric conditions, depression, stroke, and schizophrenia. These effects are mediated via the autonomic nervous system, the enteric nervous system, the immune system, and bacterial metabolites. And there likely are relationships to the endocannabinoid system. A lot of this is related to diet. Certainly, the modern diet is lower in fiber and much higher in pro-inflammatory compounds, fake fats, and fried foods. So these global dietary shifts have led to skyrocketing rates of obesity, gut problems, other autoimmune disorders, allergies, diabetes, cancer, depression, and neurodegenerative disorders. How is it that the microbiome affects behavior? Well, again, it appears that multiple probiotic species seem necessary to protect against disease-causing bacteria and likely exert positive neuropsychiatric benefits of their own. In metabolic syndrome, what can be done? The combination of probiotics, these beneficial bacteria, with prebiotics, the things that they eat, that combination is called a symbiotic. If bacterial fragments in the gut from disease-causing bacteria get into the bloodstream, this produces what's called a metabolic endotoxemia, or poison from within. Probiotics may help control PPAR gamma, which is a nuclear receptor and has been called the master regulator of adipogenesis, fat formation, also affecting tumor necrosis factor alpha in inflammation. So these prebiotics are often found in fiber-rich foods like beans, called galacto-oligosaccharides. They decrease tumor necrosis factor alpha, which is very prominent in MS, inflammatory bowel diseases, and other autoimmune conditions. Prebiotics change the microbiota. They reduce the fat development and stabilize the gut barrier, so you don't have release of these endotoxins. The CB2 receptor levels correlate to concentrations of the lactobacilli commonly found in yogurt, and negatively with Clostridium or Clostridioides, particularly Clostridioides difficile, as it's currently called, which is a common cause of hospital-acquired chronic diarrhea. Very interesting study from Canada showed that Lactobacillus acidophilus, as found in yogurt, modulates intestinal pain and affects both opioid and cannabinoid receptors. So the specific strain of lactobacilli, when given orally, induced the CB2 receptor gene, its MNRA expression above that of normal. And this also caused an enhancement of pain reduction in rats. And that benefit was inhibited by a CB2 antagonist, the synthetic AM630. There's often been debate about what cannabis use does to people's weight. But this was pretty definitively assessed in this study of obesity and cannabis use based on two national surveys called the NESARC and NCSR. So the adjusted prevalence of obesity were 22% and 25.3% in non-cannabis users the year before this study. Obesity rate was 14.3% and 17.2% respectively among participants using cannabis at least 3 days a week. So that was about a third reduction over the non-users. This wasn't related to tobacco smoking or other identifiable factors. After adjustment for sex and age, it appeared that the use of cannabis was associated with body mass index differences in both samples. Another study that showed this was, again, this study from Canada, looking at the gut microbiota in mice that were treated with THC. So THC altered the microbiome balance in obese DIO mice and affected the Firmicutes bacteroidetes ratio. THC prevented the ratio increase or weight gain in these mice despite a high-fat diet, so normally prone to obesity. I requisitioned these diagrams to show the situation in humans. So we've had various stereotypes about cannabis users. This is one that's prevalent, the lazy slacker stoner, basically a couch potato, as you see here, and with bad habits. The other is the skinny hippie. Now, people may attribute that to being frugal or poor, but this guy looks healthy. And the actual winner, the truth of the matter is, cannabis use leads to a more lean body type. Um, so in this instance, the slacker stoner is not the true representation. A little bit more about fiber and prebiotics. So inulin and what are called fructooligosaccharides are prebiotics, the feedstock for the beneficial bacteria in the gut. When these are taken orally, they get through the stomach acid and are digested in the upper GI tract, and then fermented by intestinal microbiota, of which there are over 1,000 species. Again, they stimulate the growth of bifidobacteria and lactobacilli with the benefits that can come from that. Inulin is a non-digestible agent or starch. Ancient humans were estimated to have an input of this of 135 grams a day in a heavily vegetable diet. There are only several grams a day in the modern Western diet. Best sources are acacia fiber, also known as gum arabic, things like chicory, burdock, sunchokes, onion leeks, and garlic. These prebiotics reduce infectious diarrhea, alleviate symptoms of inflammatory bowel disease, they reduce colon cancer risk, they increase mineral absorption, lower cardiac risks, and decrease obesity. Probably the best is acacia fiber. This comes from a tree in Africa. The dried exudate is, again, non-digestible by humans, but great for bacteria in the gut. In a study comparing inulin and placebo to use of gum arabic, 10 grams a day, bifidobacteria were vastly increased, as were lactobacilli. Very important, what's now known as Clostridioides difficile, big cause of infectious diarrhea, was statistically significantly decreased. So what's a person to do? Well, these are some examples. For probiotics, there are various sources, yogurt being the best known. It should be a live culture. That's very important. And preferably with multiple species. There's some products where there's one strain of bacteria. It appears important to have a variety. And these would also come from lacto-fermented vegetables, such as refrigerated pickles or sauerkraut. Prebiotics, again, would be the vegetative matter that we don't digest, but the bacteria love. And you see examples here. Again, acacia fiber, burdock, marshmallow, and slippery elm. This is just what the vegetable sources look like. Coming from the top, left to right, we've got acacia senegal, chicory root, sunchokes, what used to be called Jerusalem artichokes, and the next dandelion greens, burdock root, and then the Alliaceae, leeks, garlic, and onions. This is acacia senegal. Gelatin is also helpful to the gut, although animal source. I'd like to spend a little time talking about herbal bitters. Bitter is a taste that really appealed to humans in the past. Modern vegetables and fruits have been designed to be sweet and have eliminated a lot of the bitter tastes. It turns out that bitters are very important. There are receptors for these in the gut, but also in the brain, as it turns out. Bitters allay hunger via hypothalamic mechanisms and endocannabinoid associated mechanisms. They can lead to maintenance of a more healthy weight and counteract the metabolic syndrome. So this is an area that requires additional research, but should be very important in the future. These are 3 books, a couple on how to make bitters and how to incorporate bitter agents in the diet. Back to the skin, something we touched on earlier. There are relationships between acne and neurodegenerative disease, particularly Alzheimer's disease. Much as Alzheimer's disease is uncommon in non-industrialized societies, the same is true of acne, and there seem to be parallels between that. Both are associated with altered microbiomes. The TRPV4 that we mentioned before in relation to cannabidiol is implicated in the pathogenesis of Alzheimer's disease. And again, CBD is an agonist there, also affecting acne. Among the terpenoids, limonene, linalool, and pinene suppress Propionibacterium acnes, as does cannabidiol. That's the bug that feeds on the sebum and produces acne. So the intestinal microbiota, skin, inflammation, and psychiatric symptoms are intertwined in what's called a gut-brain-skin axis. A couple of books on how to eat. I can say that in my neurology practice, I used the Nourishing Traditions book, which is an anti-inflammatory diet based more on how our ancient ancestors ate, and saw great value in this in a variety of neurologic conditions, particularly multiple sclerosis. More recent book by David Perlmutter, a neurologist, called Brain Maker. A little more on the gut-brain-skin axis. Propionibacterium acnes is not only in the skin, it can be in the gut and gets into the brain and has been associated with beta amyloid and neurofibrillary tangles found in the brain of people with Alzheimer's disease. All of this put together, particularly for neurology, we hope that all this knowledge about the endocannabinoid system will lead to better treatments for pain, epilepsy, tumors, Alzheimer's disease, Parkinson's disease, and traumatic brain injury. We will have a separate module about optimizing the endocannabinoid system, but these are a few things for you to understand at this time. Aerobic activity at a moderate level, not excessive, increases endocannabinoid tone. We're certain that lifelong education improves cognitive function. Again, anti-inflammatory prebiotic and probiotic diets with saturated and monounsaturated fats and omega-3 essential fatty acids and bioflavonoids is coming from berries, fermented foods, and minimizing carbohydrates are all advantages for the endocannabinoid system and life extension. Many people, however, need to supplement with cannabis extracts, and we'll go into the different components and their roles in treating different diseases. And that is it for this module, and hopefully we will address some questions of interest.
Thank you so much, Dr. Russo, for that fabulous presentation. Yes, we do have some questions. So would you mind just giving us a maybe simplified explanation of what is a receptor?
Sure.
Thank you.
So it can be thought of as a lock and key model. The lock is where the compound of interest will lodge, and it's got to be the right conformation to stimulate the receptor or bind to it at all. So if there is an acetylcholine receptor, and there is a synthetic chemical that resembles acetylcholine and can act there, it then can stimulate that nerve pathway, or it can inhibit that pathway. So the lock and key model works well, but again, you have wrinkles like negative and positive allosteric modulators. That would be like a little spot on the lock um, that acts as a safety or greases the skids, as it were.
Thank you. That was also one of my questions. So, how does the endocannabinoid system work with the other systems of the body? Is it working independently or is it more integrated?
It is more integrated, and we'll think of this best as the regulator. It's sort of the thing that keeps everything else in line. So it has turned out to be key to almost every system of the body's workings. So any aspect of physiology has some role for the endocannabinoid system in making it work more effectively.
Great. In regards to endocannabinoid tone, is it some, you talked about low endocannabinoid tone and high endocannabinoid tone. What is really desirable for optimum health?
Well, like so many things, it would be somewhere in the middle.
Mhm.
As we've heard, there are deficiencies in endocannabinoid function. Clearly in migraine, that's proven. Seemingly in irritable bowel syndrome, fibromyalgia, and many other disorders. Again, proven in post-traumatic stress. So that is undesirable. Excesses are present in metabolic syndrome and diabetes mellitus type 2. Similarly bad for one's health. Again, somewhere in the middle is what's desirable. And fortunately, there are things to be done in this regard, whether it be lifestyle, um, uh, particularly exercise, good diet, prebiotics, probiotics. Uh, One other thing I didn't mention is singing has been shown to increase endocannabinoid levels as well.
All right, excellent. Thank you. And when the body isn't producing enough endocannabinoids and someone supplements with phytocannabinoids, is that something that rectifies this imbalance in endocannabinoid tone permanently, or is that a short-term fix?
It likely would be something that needs to be maintained, right? But again, dosage is key. Low doses of THC seemingly increase endocannabinoid tone. If, however, it's used to excess, it actually will cause the receptors to involute, um, cut back. So it will actually lower the tone. Again, moderation in all things seems to be the best prescription.
And why is it that phytocannabinoids at the same dose may have one effect on person A and affect person B differently?
Well, we are all different. It's not clearly related to body mass. In other words, we have situations where a petite woman needs a higher dose of THC or a cannabis-based medicine than a linebacker who might be 100 kilos. So it depends on this concept, which again is a little nebulous at this point of endocannabinoid tone. So what is the person's base level of endocannabinoid concentration? And what is the status of their receptors? Are their receptors abundant? Are they active? Are they inactive? So these are things we can't easily study, I'm afraid. Um, we don't have, you can scan related to this function with a positron emission tomography, PET scans, but these are extremely expensive and rarely available. Um, a direct measure would be from the cerebrospinal fluid done by a lumbar puncture or spinal tap. That's an invasive procedure. We can look at the serum levels of the endocannabinoids, but those don't always mirror exactly what the levels are in the brain. Additionally, it's a very hard thing to study. In the bloodstream, the endocannabinoids are highly unstable. So a sample has to be taken, put under liquid nitrogen immediately, and sent to a specialty lab that has the ability to look at them. So as much as we talk about endocannabinoid tone, it's something that we infer from the patient's history at this point, rather than measuring directly.
Along the same lines, you mentioned that infants and children have a higher density of cannabinoid receptors. Why is that? And at what point in a human development do we see a dip in receptors?
Uh, well, it's a difficult thing. I mean, one explanation is it may be why kids appear to be naturally stoned. Um, but we know historically, and this was really evident in the 19th century when uh, THC abundant cannabis was brought from India to Europe and North America. And the phenomenon observed was that children were tolerant of much higher doses of cannabis than correspondingly in adults. Um, Also demonstrated in a study in Israel, Professor Meshulam, along with Dr. Abrahamov, they used Delta 8 THC and showed it to be extremely effective in allaying nausea in children receiving chemotherapy. And very few of the children under 10 showed any signs of intoxication, even though the doses were relatively high and would have likely caused quite a bit of intoxication in an adult. So again, this is a hard thing to study. Most of the early studies were done in post-mortem tissue, but it's a phenomenon that really deserves a closer look.
Mhm. So, a lot of naive cannabis users will report that they don't really have an experience. There was no effect for them the first or the second time that they use cannabis. Will you address why?
Yeah, it's what's been termed reverse tolerance. Um, it's still a bit of a mystery. But again, it may relate to a couple of things. One would be a learning curve. That people might appear to be intoxicated to their friends or family, whereas they don't recognize it.
Mhm.
But additionally, it seems that there's a threshold effect here, and it may relate to underlying endocannabinoid tone. So one person may feel it the first time and another does not. Um, we know in general that 2.5 milligrams of THC by oral route is a threshold dose for most people. 5 milligrams is going to be a moderate dose and is recognized by some experts as a standard dose. 10 milligrams is going to be too much for the average uninitiated person. But for someone who's developed tolerance and has downregulated the CB1 receptors, even 10 milligrams may not produce much of an effect. This is one reason that people who are chasing a certain level of intoxication on a daily basis may require higher doses or more potent, potent preparations.
So, when we talk about the CB receptors, you mentioned that one of them is associated with the reward pathways. So, does that mean that cannabis can be addictive for some?
Well, that's a complex topic. But in fact, cannabis, rather than being a gateway to use of other substance, seems to be an exit drug. There are people who become dependent on cannabis, but the rates are much, much lower than for other substances, whether it be nicotine, caffeine, alcohol, or opioids. The figure that's used in the literature commonly is 9% of people who try cannabis will become dependent. However, that's very much skewed in the United States by the fact that 60% of people who are in treatment for cannabis dependency are there because of legal issues. In other words, they've been diverted from incarceration into a treatment program. So the true rate is probably under 5%. But, in comparison, the person who tries heroin is likely to get hooked very early on. And additionally, as we'll discuss more in subsequent modules, withdrawal, when it occurs with cannabis, and mostly doesn't, but when it does is quite mild and limited, might consist of feeling a little irritable, having difficulty sleeping, but rarely lasts more than a few days, does not lead to withdrawal seizures, seeing pink elephants, or other serious addiction associated withdrawal effects.
Can you discuss the potential biphasic nature of cannabinoids? And you might be covering this in a later presentation, but
Certainly. Well, but important. Most of the cannabinoids tested have what's called a biphasic dose response curve. That means they'll do one thing at a low dose and maybe an opposite thing at a higher dose. Um, as one example, THC is well known for reducing nausea associated with chemotherapy at low doses. At very high doses, people can get sick from THC. And in its most extreme form, in chronic use, can lead to a thing called cannabinoid hyperemesis syndrome, CHS. This is very serious, vomiting, abdominal pain, nausea, and hot bathing behavior that stimulates the TRPV1 receptors and seems to reduce symptoms temporarily. So we'll certainly be addressing this in more detail.
so in along similar lines, will you touch on why cannabis overdose does not result in death like opiate overdose can?
Sure. Um, Overdoses of THC can lead to difficulties, as mentioned, vomiting. It can also lead to vasovagal syncope or orthostatic hypotension. This is where the person loses blood pressure and may fall and hurt themselves. So it can be quite serious. It also can lead to what's called a toxic psychosis, where the person may be paranoid, delusional, etc. But these are all rate limited. They'll go away in a few hours and often will respond to being talked down. Um, yeah.
All right. I'd like to sort of transition to the feeding of the endocannabinoid system and the microbiome, something that is a favorite topic for both of us. Would you say that directly that diet impacts the endocannabinoid system?
It does, but it may not be a solution itself. So certainly, in general, we encourage people to have an anti-inflammatory versus a pro-inflammatory diet, to increase vegetable matter in their diet, incorporate fermented foods. And these are all going to be health giving. And, even if it were not the case that this improved endocannabinoid tone, there is a superabundance of evidence that this will lead to lower inflammation, a leaner body mass, a less likelihood of cancer, and heart disease, and a longer life and a healthier condition. So I'm not sure that there's too much debate there.
In regards to bitters, how would you recommend that people who want to take the leap to use them, what do you suggest?
Well, there are a variety of products on the market. In the slides, if people look carefully, they'll figure out what they are. Um, but eh, these are comprised often of mixtures of different herb agents that have a bitter taste. And often the combinations are advantageous. Um, a really convenient way to do it is have a little vial, spray vial, and take something like 7 sprays in the mouth 15 minutes before dining. Um, Initially, people are maybe put off by the taste. Interestingly, most people who do it regularly come to like the taste and may incorporate more bitter herbs in their diet. And again, it's well established that this is health promoting.
Right. For one of our final questions, I kind of want to go big. And we have a lot of talk right now in the healthcare industry about individualized medicine. And so what role does the endocannabinoid system play in us moving towards better individualized medicine?
Whoa,
Yeah.
tough topic. Um, for the fortunate patient that's found a doctor that has the time and interest to address this, I would see it as key. What about their health pattern indicates the status of their endocannabinoid system? Is it optimized? Can they do from the standpoint of diet, lifestyle, or phytocannabinoid supplementation, we'll call it, to make themselves better and address the disorders that they have?
Great. Do you have any final comments about the endocannabinoid system that you want to leave our audience with?
No, I welcome people to the course and hope that they'll continue and learn a lot more about this. Certainly, this has been a driving passion for me the past 28 years, and I hope some of the enthusiasm that we have for this subject will be infectious for students.
Thank you. So if you guys would like to learn more from Dr. Russo's writing, please check out his library at ethanrusso.org. Thank you guys for your time and attention.
Thank you.